say there's one thing, Kristen, that I would comment on is that, and something that we tell our moms is that if they've had a previous child with a brachial plexus injury, that's a big, big risk factor for a subsequent child. And I think you mentioned that with babies getting bigger. But I think in terms of preventing, right? We really do encourage our moms who've had a previous plexus injury to have a C-section with their subsequent pregnancies. I don't know if you feel the same way.
I do actually. So yes, 100%. So I think once you've had a baby, even a baby with shoulder dystocia, because sometimes
Yes,
you'll hear
agreed.
that, and then we strongly recommend, and sometimes moms choose to go to different providers for each subsequent pregnancy, or you move around. They may not be aware of your history. So yeah, we have, and we have certainly seen families where they have multiple children with brachial plexus birth injuries. So I think that's very important. 100% agree.
Yeah, yeah. Okay, so I'm in charge of prognosis and orthosis, as Aaron has put it to me. So prognosis of brachial plexus birth injury. So why do we get imaging on some patients but not others? And why not, right? And then nerve conduction and EMG studies. So I think one of the big things with imaging is imaging, particularly getting MRIs in babies, requires general anesthesia. Now, there are people looking into doing this quicker, in a manner that's quicker, so they don't require general, with swaddling and maybe feeding them and getting them to sleep right before. But for the most part, in most centers, you're going to require general anesthesia. So we try to avoid it if we don't have to. And as Aaron said, we really save MRIs for the patients that we're going to be operating on early. And so we try to push that MRI off as long as we can. Now, in terms of nerve conduction studies and EMG tests, I think what's interesting is that a lot of patients get referred to neurology early on, and neurologists love to make a diagnosis. And so they're going to do everything they can to sort of find, to delineate exactly what the plexus injury is. Whereas we, as surgeons who are taking care of these injuries, don't really need EMG studies or nerve conduction studies. And part of it is because studies that have looked at these studies have shown that they actually make your ability to predict outcome or prognosis is worse if you get an EMG than if you just use your clinical exam. So it actually makes your ability to predict the injury worse. So the most important.
Why is that? Just out of curiosity. I mean, I don't want to slow you guys down too much, but these things are.
Yeah, no, I
love. As a parent, I'd be like, what?
Yeah. So why do we not use it? Why is it actually problematic? And why do people still get it? Those are the three questions you want to know.
Yeah,
right?
basically, yeah.
Yeah, so why do we still use it? I think is because probably lack of, it's not such a common thing that neurologists are dealing with on a regular basis, and it's probably a lack of understanding of the disease process and the specificity of requiring these things in this patient population. So if you're a neurologist, you see a nerve injury, you get an EMG, that's a very common thing. It's kind of a knee-jerk response. But in this situation, what happens is the reason that we look at electrodiagnostic studies like nerve conduction velocities and amplitudes of nerve conduction, what we're looking at is, if you think of a nerve as just basically a wire conducting electricity, right? Think of it like a speaker wire going to your speaker or a wire going to your outlet, right? You can measure the amount of electricity that's going through that wire and how quickly that's moving, right? Yep. How quickly it's moving is a factor of how well insulated that nerve is, right? If you're losing a lot of electricity around, it's not going to conduct quite as quickly. But if it's well insulated, it'll travel very fast. And then the other thing is how much current is being carried by that wire, right? Mm-hmm. If you have a lot of current, then that means that there's a lot of wires in that one cable that are carrying that current. And if you have very little current coming across, that tells you that the wires have been disrupted, right? And so we look at both sensory and motor. So we look at both the wires that carry sensory information. That means information about touch and pain and heat and that kind of thing back to the brain. And then there's information about carrying motor function to the hand or to the arm, whatever it is, to your biceps, right? So when we look at, so one of the things that Aaron talked about was avulsions versus ruptures, right? And so the role of EMGs in adults is to look at whether or not the injury was an avulsion or a rupture. And we can tell that because what's interesting about avulsions is that they will maintain, because of where the injury happens, they will maintain sensory conduction, velocity, and amplitude, but they will not feel. And they will not maintain motor conduction. So if you see in a child that they have preserved sensory but absent motor on the nerve conduction studies, that tells you it's avulsed. The problem is not all injuries are clean, meaning it's not that you get an avulsion right away. Sometimes you get a stretch injury first and then an avulsion. And so it'll look like it's an avulsion or not, and you don't really know. So I think that makes it a much more complicated picture. And then in terms of EMG, EMG tends to overestimate the amount of potential recovery because of something called sprouting, where the nerves actually, what they do is the muscles actually start to work better than you think they look electrodiagnostically, but not clinically. And so all these nerves start to sprout, and they actually can innervate a lot of motor fibers, but they don't do a very good job of it. So electrically, it looks like the muscle's more active than it actually is. And so it tends to overestimate the amount of recovery you're going to see. I don't know, Kristen, you have any other thoughts on that?
No, the only thing I was going to say is that that is more particular to babies than adults.
Yes.
Yes.
Yes,
So
absolutely.
everything he's saying is very particular to the baby scenario. It doesn't even apply to older children who, let's say, were in a car accident or something. This is unique. This is a unique thing to babies, where EMG and nerve conduction studies have been shown to be overly optimistic in terms of their recovery.
That was something I only learned in the past year. You know, I was injured as an adult and learned all this mostly the best I could, but the baby prospect and the sprouting conditioning, it makes sense once I understood it, but I just did not expect it. And I can just imagine, you know, parents getting information from one person or another, be it a friend or a physician, saying, "Oh yeah, you should get this for sure," and then getting another voice that says not to. It's just trying to remove the fog. And just last one with that, with the MRIs before surgery, but not necessarily for diagnostic. And is that because they're not necessarily in diagnostic tool so much, but for surgery, you're knowing what you're getting into?
So, you know, because it comes down to this, the MRI is not perfect either.
Yeah.
The MRI is much better than the EMG, and that the EMG actually worsens your ability to predict the type of injury. The MRI makes it a little bit more reliable, but it's a combination of your imaging, your clinical examination, and serial examination, which is what we're going to get into now, which is really important, is how the baby changes over time really informs what type of injury you've had. And that's very critical.
Yeah, I like to say that MRI is a very static image. It can show you that something's been injured and what nerves have been injured. Even that's not perfect, but it doesn't show you how it's going to recover, which is what we need to know.
Yeah, and for us, it's really a tool to inform our operative decision making. It is not a decision. It doesn't help us make a decision about whether to operate or not to operate. I think that that's based on the clinical examination. Again, this is pretty unique to babies.
Yeah, that's
I
important.
think MRIs in adults or even children with traumatic injuries, because it's a much more violent injury. If you think about it, a birth is not as violent as a car accident or you know, motorcycle accident, something like that. Okay, so
Thank you. I appreciate that. Helps a lot.
love it. Please interrupt at any time, because I think if you're having the question, other people are having the question as well. All right, so anyway, so that brings us to the role of serial assessment, which I think is the most important thing. for examination. So you really want to measure what the baby is doing. That's motor function. And the reason we do serial assessments is we're looking for changes. We're looking for what has changed. So for example, if we have a child who has no finger function at birth, but then at 2 weeks or so gets finger flexion back, we know the type of injury that has happened in the lower trunk or in the T1 nerve root. That gives us an idea of that. If that T1 function recovers at 2 months, that's a very different picture of what we anticipate to be the injury. And it really informs the way that we treat those kinds of injuries. So knowing when things came back is really important. So we usually do our examination monthly, and then we look to see how severe the injuries are. Mild injuries where very few axons are compromised and it's mostly just the insulation of the nerve, those usually resolve within about 2 months. If you have moderate injuries, and by the way, if you resolve by 2 months, most people will say, and the data shows that those are the ones that recover fully or have very, very little deficit once you recover by 2 months. So that's sort of a critical number. And then moderate injuries where you have some axonal loss, which means you have some of those nerve fibers are torn, but not necessarily all of them. Those usually improve by about 6 months. And then severe injuries where the nerve itself is torn completely or avulsed, those improve a little bit or not at all by about 6 months of age. So avulsions, as Aaron said, really do show no improvement.